Just waiting to see anyone else move in there. No, the recording started. Thank you very much for joining us this morning. And you're very welcome to everyone who's coming as part of the meeting or as a visitor to us this morning. Welcome to you all. We have some apologies this morning. We have June Brown, Sandy Riddle and Alex Stephen, as far as I know, sent in apologies for this meeting. Anyone else that has apologised? Sarah, do we know?
Not of the executive board members, but we also have apologies from Paul Allen, Leslie Hall, Stuart Humphreys and Lorraine Scott.
Okay, thank you. Thank you very much for that. Thank you. Right, we'll move on then to declarations of interest. Please, any declarations of interest to make for this meeting? No declarations of interest. Thank you. So move on then to the next item, which is the Chair's opening remarks. Obviously, welcome again to all of you to this June meeting of NHS Grampian's board. I would like to start today by thanking all of NHS Grampian staff and members of the public who contributed to make Grampian Pride last weekend such a successful and memorable event. Grampian Pride continues to go from strength to strength, and as well as being the biggest attendance from our staff yet, the sun shone and Union Street was once again full of colour and noise. Events and occasions such as this are a powerful symbol of inclusivity, and our involvement undoubtedly demonstrates our support for our staff, partner organisations and the communities we serve. The Daisy Awards. Also on the topic of staff support, I would like to acknowledge NHS Grampian's participation in the Daisy Awards as referenced in Caroline's Chief Executive Report. Daisy Awards recognise the superhuman efforts of nurses for patients and families every day, wherever they practice, in whatever role they serve during their careers. Our participation places us among esteemed company as one of 36 organisations taking part worldwide, and this was rightly welcomed in a parliamentary motion last month. Thank you to all involved in that. On behalf of NHS Grampian, I would also like to welcome One Biohub, which formally launched earlier this week to our Forester Hill campus in Aberdeen. This new facility incorporates incubator laboratories and offices that bring scientists, innovators and investors together to turn research into businesses capable of tackling modern health challenges. The University of Aberdeen and NHS Grampian are strategic partners, and I am sure this welcome addition to our campus will become a focal point for life sciences nationally and internationally. So thank you to everyone involved in that. I would also like to acknowledge the update noted in Caroline's Chief Executive Report this month regarding the Baird Family Hospital and the Anchor Centre, ahead of a much more detailed progress report at our August meeting. Construction of the Baird Family Hospital and Anchor Centre continues to be closely followed by the board, so I'm pleased to hear that the Baird and Anchor project team and infection prevention and control colleagues continue to work with Performance Assurance, Finance and Infrastructure Committee and NHS Assure to address the issues previously reported around ventilation and water systems issues. NHS Grampian is immensely proud of these landmark projects and remains committed to ensuring these complex modern facilities meet the needs of the population we serve when they begin receiving patients. To that end, and in the interests of openness and transparency, I'm pleased to be able to advise that site visits with elected officials are underway and ongoing to showcase all that has been achieved to date. Lastly, Kim, this is the final board meeting of Kim Cruttenden, and I would like to extend the board's thanks to Kim, who will shortly step down from her role as chair of the Area Clinical Forum. Kim's term as ACF chair is coming to an end, and the board would like to acknowledge the significant contribution that she has made during her time in this role, and also, of course, give our immense gratitude to Kim for all she's contributed to the work of the board. Thank you very much, Kim, for having served the board so well in your time here. Thank you. Thank you for that. With that, we move on to the minutes of the meeting of the 5th of April 2023. Can we agree those minutes, please?
Agreed.
Thank you. Are there any matters arising from those minutes? Oh, Derek, sorry, Derek.
Thanks, Alison. On page 8 of the minute, it says 85% of income-deprived population do not live in deprived areas. And I was wondering, that sounds very high. Is that the correct number?
I'm going to have to seek advice from someone else on that one.
Yes,
Susan, thank you.
it is.
Thank you. There's assurance from Susan, Derek, for that one. Okay.
Yeah, thank you. Thank you.
Thank you for that one. Caroline?
Thanks, Chair. I have an item under matters arising.
Oh, thank you. All right. So with the clarification for Derek, then, can we just confirm we agree the minutes of 6th of April?
Agreed.
No one's spoken otherwise. Thank you. Okay. So matters arising. Caroline, please.
Thanks. So it was just in relation to the discussion that we had relating to the performance assurance framework, and to update the board that there will be a further collective exec team session on the performance assurance framework on the 9th of June, and then it is scheduled to go to the performance PAFIC committee, on the 28th of June. So it was just to update from the note on timeframes.
Brilliant. Thanks for that, Caroline. Thank you. And Tom, please.
Yeah, thank you, Chair. It was just to note that in the conversation around culture that's recorded on page 5, and sorry, I wasn't at the April meeting, so this is probably why I've got the query. It highlighted that a future board meeting would receive an update on the work of the Culture Collaborative. Now, we had a full update on culture and staff experience at the Staff Governance Committee that followed that board meeting on the 18th of April. So I just wanted to check if there's anything more that is required to come to the board, because the Staff Governance Committee did indicate that it was assured by the information provided around culture and staff experience at that meeting.
Okay, thank you, Tom. I'll just check with anyone else would like a further briefing to the board, anyone who wasn't able to attend that meeting, or does that fulfil what was expected from us at the last meeting? No one's commenting, Tom, so I take it from that the update given that staff governance covers that item off. Thank you. Thank you very much, Tom, for bringing that up. Okay, thank you very much for those contributions there. We move on to item 5, the Chief Executive's report. I will hand over to Caroline to update us. Thank you, Caroline.
Thank you, Chair and colleagues. So as you have previously heard from me, the purpose of this report is to make sure that we keep you as the board and the public as up to date as possible on the work that is ongoing from when we last met. And so really this is taken in combination with the How Are We Doing report, but just provides a bit more information. So the report, I hope, is self-explanatory. I hope conveys in combination with my opening comments of the How Are We Doing report, which is next on the agenda, despite the challenges that we continue to face across the system, we continue to do everything we can to move forward, not just with improving and stabilising our system, but also moving towards our strategic intent. So the topic headlines that I've covered in the report are our continued engagement with Scottish Government, the ARI bed-based review, which I'm sure will have triggered some interest. So happy to give a bit more detail on that and how that fits into other plans. Our ongoing and critically important focus on developing and embedding systems leadership in our system. Apologies for my phone ringing. Obviously, the Chair has made reference to Baird and Anchor and Daisy, which are both covered in this overarching report. So again, able to take some questions on that. And really positively, just wanted to include the opening of the 2 ligature wards in Royal Cornhill Hospital, which has been long awaited by colleagues in Cornhill and also for patients and citizens that utilise that care environment. So a positive piece of news there. I'm not going to add any more narrative to the report, Chair, but happy to take any questions.
Thanks, Caroline. That's all very helpful. Thank you. Open it to any questions or comments from anyone, please. John first, please. John.
Okay, just off mute. Thank you. Yes, it's the bed base part of the report, Caroline. So that's really interesting, and I'm assuming that the work behind that is putting in place modelling in terms of the demand that will need to be met. Is that in looking at the short term, but then also over the potentially the 10-year period of the strategic intent in the plan? And will that dovetail with what we're trying to do in the community in terms of demand? So it's just, I know you can't say what's going to come out of it, but it's just to be assured that it deals with the immediate pressures, but also a projection to what might be needed over the course of the plan. Thanks.
Thanks, Caroline.
Thanks, John. So I'll say a couple of words, then I'll hand over to Paul, who is the executive lead for this piece of work, Paul Baku. So this absolutely is a focused piece of work to stabilise our system, to allow us to go into this winter with the best opportunity of reducing distress for patients and for colleagues, and for maintaining safety, as well as maximising access to all of the services that we know are particularly challenged. Everything we do within that, all of the data analysis, will be cognisant of both our strategic intent and our absolute way of working, which is whole system and incorporates our processes in the health and social care partnerships, primary care, etc. So it will not solve all of our problems by any stretch of the imagination, but it is the first step forward in redefining what our inpatient bed base needs to look like in relation to the change in demand profile and our data analysis and realisation that a secondary care bed base for Grampian needs to be adjusted. So it's a really positive piece of work, but it is absolutely being driven by data, both hard data and the expert intelligence data that is put around that, the numerical data, by our colleagues. So that's my kind of overarching, but I would be keen, Chair, just to bring Paul in just to give a little bit more detail on that, because I recognise it has generated a lot of interest across the system.
Okay, thank you, Caroline, and thank you, John. As Caroline has said, this is one part of several pieces of work that will ultimately answer those questions and challenges that you've raised. This piece of work has, for the last 2 months, focused very much around understanding all of the current redesign projects and programs of work under the urgent care redesign umbrella, together with the last several years of data that look at our demand capacity gap and our headroom every winter. So from all of that information, our health intelligence team and the project point of contact is Elaine Thompson, have put together what I can only describe at this point is as a incredibly smart model that brings into play a large number of variables, which ultimately, when set through their modelling program, give an answer in terms of the ideal number of staffed ARI beds required to maintain all of the objectives for unscheduled care and scheduled care. So the important thing is it's both, and this is an initial piece of work which brings in all of those projects that sit with Sandra and other Pell colleagues across our system. So we're at the point now that we've got a pretty good model. It's been shared with lots of stakeholders. They've validated the internal validity of the model. The numbers look about right, and we're planning a multi-stakeholder event across all of our systems, which currently amount to about 80 to 90 people, towards the end of June at Pataudry, to share the model and work through things. That's where we are at the moment. And what I would say is it's producing some very interesting data, and when we can share it, we will. And it also really highlights how hard the current workforce is doing and has done over 3 years to provide the care that they have without those beds that the model is going to identify. So all those patients are still in our system. So that's where we are. And absolutely, it's phase 1 of several phases. Thanks.
Thanks, Paul and Caroline. It's obviously a very key piece of work there, and echo the thanks to the staff for the work being done as well. Thank you for that one. John, happy with that?
Yes, it's extremely positive, and look forward to seeing more on that in due course. Thank you.
Brilliant. Thanks very much, Tom. Thank you. Luann.
Thanks, Alison. Caroline, my question, I'm interested to hear a little bit more about the conversation that the Chief Exec team had with Scottish Government, where you're describing the ADP and the scale of the challenge and the need to shift resource towards early intervention and tackling inequalities, just to get a sense of what their support was around that, because I'm very aware that there's, rightly so, a focus on the here and now and this winter, but is there also a support for that longer term work that we need to do as well?
Caroline?
Thanks, Luann. So the context of that conversation was under the auspices of our sponsorship relationship with Scottish Government, which is just developing. And so it is really there for us to discuss what matters to us as NHS Grampian with senior colleagues from Scottish Government. So we took the opportunity to discuss this year's delivery plan and some of our thoughts, both opportunities and challenges. So my reference to the acknowledgement of the issue that you raise, I would absolutely say that there is a will and a desire to focus on prevention and on the aspects of moving to all the stuff that we've talked about in our strategy, self-directed, preventative work, empowered communities, and all of that. So there is an absolute clarity that there is a desire to move that forward from us, and that is coherent with the policy direction. There is a genuine level of interest and support for the work that we are doing. And there is also a collective understanding of the financial challenges of trying to move any financial resource to that agenda while we try to deal with the current pressures. So I would suggest that that continues to be an open dialogue, and that we will continue to use every opportunity that we have with innovation, with new ideas of how we can do that in the north, and work with the support of Scottish Government. So there was no explicit this is what we can do to provide additional resource, but my messaging from that is the door remains open for us to continue to work collaboratively on that. There were a range, in fact, the full exec team were with me on that call, so if any of them want to jump in, that'd be great. But I think that's in summary where the conversation took us.
Thank you, Luann. Does that help?
Yeah, that's really helpful, and I really welcome hearing that that's an ongoing dialogue and a supportive relationship with Scottish Government colleagues. Really important. Thank you.
Brilliant. Thank you very much. Thank you. We move to Derek, please.
Thanks, Alison. Just wanted to say that it's really interesting to hear what Paul's saying, and really look forward to seeing the outcomes of that particular study. That's really good stuff. And I just wanted to say that the written report, a significant upgrade on the verbal report. It's much easier to understand when you've got it written down. So thank you for that. Thank you.
Thank you, Derek, and we'll welcome that feedback as well. Thank you very much for that. Thank you. Joyce, please.
Thank you. Yeah, I just wanted to thank Paul as well, because I was going to ask a question about why is it taking so long to count beds, but I realise after that explanation it is much more detailed, in depth, and indeed will stand us in good stead for the long term. So I'm very assured about what's happening, and thank you for that very comprehensive explanation.
Thanks very much, Joyce. And again, thanks to Paul and Caroline for the work involved in the bed-based review. Thank you. Derek, are you coming back, or is that a legacy?
Yeah, legacy hand.
Thank you. Thank you. Dennis, please. Dennis.
Thank you, Chair. Caroline, it's really just to expand a little more on the discussion from Luann there. In terms of where we are in terms of the development plan, not the relationship with Scottish Government, but our relationship, a sort of pan-Grampian relationship in terms of working with the partners, in terms of tackling or the whole preventative aspect on a pan-Grampian basis, on a sort of one system. If that is that the intention, is that your thinking?
Caroline?
Maybe not one system, but whole system.
Yeah, thanks, Dennis. I mean, I think the challenges that we face across public sector, and I will talk specifically about health and a bit of social care, from whichever angle you look at it, be that fiscal, be that workforce, be that population health, no single entity can move that forward alone, is my view, and therefore the way in which we work collaboratively, I think will achieve the most for the population. I believe our population don't see us or experience us as separate organisations. They see us, of course, they see the names of our separate statutory bodies and how we work, but their experience of care, health and care, is very intertwined, and therefore the more we can work in that way, the better. So I think if there are, so particularly with a fiscal frame around this, if there are efficiencies that we can make that reduce cost and that reduce confusion and duplication, we have a leadership responsibility to do that. However, what I would be really, really keen to assert is that does not mean there is one size fits all for the multitude of diversity that sits across Grampian. And we know that the closer we can do our work with communities and empower communities to help us to design our systems as effectively as possible, is going to move us much more effectively towards our strategic intent of improving our population's health and addressing inequality. So I definitely think there are opportunities for us to work. Examples of that would be in relation to population health and what are the core aspects that we wish to mobilise as partners with society to move forward. And we've got different constructs around that. The North East Alliance, we've got our newly established Population Health Committee, we've got the long-standing CPPs. So I think the more we can work together, not for homogenous approaches in totality, but definitely for a focus on what are the outcomes we're trying to achieve, that can only be a good thing for all of the reasons that I have outlined. Dennis, does that answer your question?
Absolutely, and I can only say that I think, you know, the the concept of working collaboratively across the piece is something that I think, you know, I think we would all welcome. So, but thank you very much for that. Thank you.
Yeah, thank you, Caroline. It was really good to hear that articulated, that vision and the direction of travel that articulated by you then. That's really important to show the way we're working at the moment as well. So thank you. Tom, did you want to come in on that or on something else?
Yes, thanks, Chair. It was just really to make the connection between that last piece and the event that we had with senior system leaders in May from across the Grampian system, so from across the northeast. It was well attended, not just by NHS Grampian colleagues, but also by colleagues from the Health and Social Care Partnerships. And I think one of the kind of key themes that came out of that was around cross-boundary working within our own system and ensuring that we've got real clarity on the role of partnerships in progressing some of these issues in a collaborative way. And particularly, you know, there's a big theme around working upstream and ensuring that focus and attention is given to prevention. So I think that is really that was a really strong theme coming out of the work done over those 2 days. And there have been follow-up sessions already with participants in the wider system leadership cohort around some of those themes and the, I guess, the actions that they will generate under the heading of building our system leadership capability. So I think it's just to join the dots for colleagues, I suppose, on the board between that update and the event that we had in May and what's been going on since then.
Thanks, Tom. That's very helpful too. Thank you. And with that, can I also say thank you to Caroline for her report and also to the feedback we've had on the report as well about how useful it is as part of our agenda here as well. So thank you for that. With that, we've obviously noted Caroline's report and had a conversation about it as well. So we'll move on now to the next item on the agenda, item 6, the How Are We Doing report. This is to review and comment on the performance data and information in each section of the How Are We Doing report and confirm that it's giving us sufficient detail and assurance about performance of the board, about system performance from January to March 23. Caroline's going to lead us on this report, please. Again, Caroline, please.
Thank you, Chair. So I'm just going to say a few words in the context of this paper and then open up for questions. So I mentioned under Matters Arising, the Performance Assurance Framework, and the How Are We Doing report is part of our continuous drive to ensure that our performance is transparent and meaningful for all. In that regard, I hope that you continue to see the development of this report and our tiered approach to performance reporting, which is described, I hope, in adequate detail in each at the beginning of the actual report. Within the report, you will note the spotlights that we have highlighted, and as I say, I am happy to enable the discussion to be the main part of this item to allow board members to explore what we've been doing in relation to the time frame that are set out. Alison, you've just set that out, and in this performance report. I think, again, I will state that our system remains incredibly challenged, and I'm sure when we get into some of the questioning, we will be able to give some of the context and detail of our understanding around that challenge, as well as some of the solutions that we are designing in our next steps to move forward. In particular, our continued challenge across the piece with access to health and care services, and just to formally acknowledge within that the pressure that puts on colleagues continuously, and also on citizens as they wait to receive care, which I absolutely recognise is distressing for all. We continue to tell some of the good stories as well as some of the challenges, and I hope that flavour comes through in the report. And Chair, other than that, I'm not going to add much more. That the intention of this report is that it is so accessible that we can move into the important dialogue and questions. Chair, I am hoping that I'm not going to go to every executive to add narrative to their spotlight report, but Sandra MacLeod is only able to join us for this part of the agenda, and is, as well as being the Chief Officer for Aberdeen City, is the Portfolio Executive Lead for Medicine and Unscheduled Care, known as MUSC, which she is delighted, therefore, to hold the responsibility and the executive lead for what is most definitely a whole system piece of work, but around our unscheduled care work. So I would be keen that I can just hand over to Sandra just to give us a little bit of additional narrative to her spotlight, and then to take questions on unscheduled care first, to allow Sandra to go, and then for other execs to respond to questions relating to the report. Thank you, Chair.
Yes, thank you for that introduction, Caroline. And of course, I will hand to Sandra if she wants to say anything first, or just open to questions. Sandra, would you like to say anything further first?
Yeah, thank you, Chair, and thank you. Apologies that I can't be with the whole meeting, and appreciate the tolerance of just letting me highlight some key things. So the performance report that I'm going to comment on is on pages 14 and 15, page 37 and 38 of your pack. So it's just really to highlight a few key things. One of the things is that you'll see that we're on amber for our performance. It's not, it's not as good as we would choose it to be. But I think is what's been understanding is that this has been a particularly challenging time right across winter, and we remain particularly challenged. This last weekend, for example, we were one of the busiest EDs across Scotland for our attendances, and that does impact on how people can access our services. One of the couple of key things I just highlight to you, a lot of the areas that are in discussion in this paper, in these two reports, are our improvement work. And just picking up on the conversation that was just there, I caught the tail of about the system-wide, how we work system-wide. This improvement works will bring us to a certain level of performance, but there are some factors that are not within our control, and some factors whereby we fundamentally work as a whole system. So, for example, we had particular peaks early January with the bad weather, so external factors such as weather, factors such as unpredicted high attendances, things that are not within our control, they will impact on our trajectories. The challenges and the impacts that we have, such as staffing, such as our financial constraints, changes in policy, all of them are well listed in the report. But the key things I would like to really have board members just see from this, that there is a huge amount of improvement work that's going on. That's one part of the picture. The other part is our bed-based review that will fundamentally work there. But the other key parts are working with our partners within health and social care, so looking at our delayed discharges. We continue to be one of the best, the lowest wards in Scotland for attendances at ED per head of population, so our primary care colleagues are certainly supporting us in those avenues. So really just, yeah, there's not much else to add. I'd rather just answer any questions that anybody has. The report's in front of you if there's any key comments, so I'll stay to answer any questions, Chair.
Thanks very much, Sandra. Thanks for that. Any questions or comments for Sandra, please? Derek, please.
Thank you, and thanks, Sandra. I was just looking for a wee bit of clarification on page 37 there. FNC, the Flow Navigation Centre, which is fine, but then down on the right-hand side, it talks about funded nursing care being FNC. Is that meant to be Flow Navigation Centre as well?
Sandra?
Sorry, I'm just looking on the right-hand side.
Right, and so our actions help us get there. And then second bullet point.
Apologies. So Derek, well spotted. It is meant to be the Flow Navigation Centre. That's an error.
Yeah, that
Apologies. I don't know how many times I've read this report and have not spotted that. So thank you very much, and we'll get that changed.
Yeah, wee typos are magic.
Wee typos, yes. Apologies for that. My sincere apologies.
Thank you. Well spotted, Derek, as well. Thank you. Joyce, please.
Yeah, I think we have to actually congratulate everybody in the team on the Flow Navigation Centre, the cath lab work, and the hospital at home services that are preventing the numbers coming into ED that we'd seen before, though it's still a lot, obviously. And we've all been on everybody's backs over the last few months, well, I have, about change and moving forward at pace. So I'm delighted to see that the results have come, and really quite excellent results in terms of percentages being dealt with in numbers. So thanks to everybody in the team for that.
Thank you, Joyce, and thank you for sharing that as well. Thank you. Caroline?
Thanks, Chair. Thanks, Sandra. Sandra, I just think it's important for us to just put a little bit of narrative around our position of being amber, and that being in relation to 12-hour waits, when actually our colleagues and citizens are experiencing extreme pressure. And we know in relation to the broader metrics around access, it's particularly challenged. So there's nothing for you to add, Sandra, other than unless you feel the need. But Chair, it was just to be clear that the RAG rating of amber relates to our Q4 position of our specific 12-hour waits, whereas if you were to ask Sandra overall in the metrics of unscheduled care pathways, where would we be, then I would imagine that RAG rating would be read in Sandra and the team's mind, and certainly we are dealing with it with that level of importance. I just think, and our learning actually from this delivery plan into next year's delivery plan, around putting in our delivery plan what is achievable, as opposed to the measures that are very publicly available and that we are performance managed on. We're going to change that around in this year's delivery plan, but it was just in case people were thinking, how can we be reporting that as amber?
Thank you very much for that clarification, Caroline, and also for the emphasis on the work that's ongoing as well to move things forward in that area as well. So thank you for that. John, please.
Okay, thank you, Alison. This is a kind of general question, but so it's relevant to this portfolio as well as the others. So I'll bring it in just now. I think for us as a board, we had the concept of portfolios in 2021. In 2022, these things started to operate, and I think in 2023, I'm quite assured now in the relation to the reports that we're getting on the individual portfolio, but also what I'm hearing today between Paul and Sandra on the cross-system work across the portfolios, but also now, I suppose, Caroline, you described it as not one size fits all, but it's almost that tight, loose thing. What do we need to do the same across, and what needs to be different? So there's that drill into the health and social care partnerships. So I just wanted to basically ask the question on that latter one. Is that joint work, I can see how strong it is with the partnerships themselves, but with our link into the IJBs, is there a kind of still a gap there in terms of the IJB awareness and this, I suppose, being the performance being owned as a system performance as opposed to individual services which might not join up as much? So I hope that's coherent enough as a question, but if any of the portfolio leads or Caroline would like to comment on it.
Yeah, I think I'll turn to Caroline, John, for that. I think there's a general question. Caroline?
Yeah, I'm happy to have a go at that, John. But again, welcome. I mean, it's Paul, Sandra, Pam, Susan, Simon, and Geraldine that have been really holding the space on how do we move this forward. So you're right. The emergence of portfolios from our historical structure has been over the last 2 years, and I think Tom referenced it in response to the earlier item about the rationale for that is about embedding systems leadership, so influencing and negotiating across traditional boundaries and working in a system that is utterly complex, and it is about moving our work forward, and really importantly having that work owned by the people that it affects, so communities, colleagues, and so that's the frame of our leadership. That is where we aspire to be, and we are, despite it being 2 years, I think we are very much at the beginnings of that. So I think as executive leads, I can tangibly see the difference and feel the difference of the way in which the executive leads for the totality of health and care work and think differently. Doesn't mean they rub along brilliantly all the time. Of course, there's that tension there, but that is worked through in a much more whole system way. And again, colleagues will comment on that. The opportunity that we have around spreading that way of working and moving from traditional managed structures to the construct of systems leadership is being enabled, and one example was the 2-day event in May that Tom referred to. So there is a lot about confidence. The vast majority of this work sits in a space of trust, and you build trust through relationships, so creating the opportunities for teams to come together naturally. So that work's ongoing. I think you highlight a really good point, however, in regards to how do we join up our governance at the statutory board level. And what is critical in that work is that we do that from a place of adhering to the governance and regulatory requirements, but also from a place of trust. So just because I haven't seen something through NHS Grampian's board, I am assured that if it's gone through, for example, City, let's use mental health services as City hosts that, if it's gone through City's processes, then we are assured as a system that governance is robust. And that's easy to put down on paper, but because most of that relies on trust, the relatedness needs to continue to build. So if I'm honest, I think as statutory boards, we have a lot of work to do to work that through as board members. I think operationally and at a strategic leadership perspective from a delivery arm, I think we are doing that. But I think your point is well made around how do we as statutory boards now start to embed systems leadership across our partnership organisations. I think there's a real will to do it, but for obvious reasons, for example, the constructs of accountability and governance that we sit in, it feels difficult at times. So I think that's going to take continued effort and work, John. And there is a specific piece of work that we are looking at across the system, and I think we've landed on clinical governance, but again, colleagues will jump in if I'm wrong around that, as an area to explore how can we integrate our governance in a different way. Performance governance would be no different in my mind. So hopefully, John, that answers your question, but I'm genuinely happy for colleagues to come in and challenge what I've said if I've got that wrong.
Thank you, Caroline. That's highlighting the journey we are on together and towards collaborative governance as well. So thank you for that. But I think Sandra's coming in on that as well. Sandra?
No,
Was that,
I think
no, sorry.
Yeah, no, sorry. Carly's covered it well.
Okay, because you put your hand up, that's fine. Thank you. John, did you want to come back? Are you happy with that? Lost you. Okay.
Yeah, sorry, no, that's fine. I think that's quite interesting. And then I suppose my other one point I'll make it just now would have been the way this is now shaped up is really, really helpful and informative. And I think I'll be interested in due course as to how we're going to share this with the public, so that we can build on what we've achieved so far. And then that'll be part of that relationship with the communities and the public. So that'll be for another board, I think. Thank you.
Yeah, that's a step on the journey, isn't it? But thank you. It's something obviously for the future as well. Thank you. Luann, please.
Thanks. thanks, Sandra, for all the work that's going on around the Musk portfolio. Clearly, lots of important improvement work has happened already. I'm interested just to understand a bit more about how we're using data to wrap care around our more vulnerable residents in our communities. I know that that's a really important part of our strategy, so I'd be interested just to understand a little bit more on what's been done around the Musk portfolio to target our more vulnerable people and hopefully prevent people coming to the front door when they could be supported in community.
Thank you. Sandra?
Thanks, Chair. Thanks, Luann. I think that we are very much, we've got a number of projects that are particularly focused around some of the more vulnerable in our in community, trying to, for example, we had a deep analysis of the attendances at ED and looked at that from areas of deprivation, looked at the key things that were coming across, looked at we had multiple people who were attending. From that was highlighted that we had in particular areas, we had people with mental health and substance use and that was then impacting on there. We worked with our ADP colleagues across the system and have worked with it, so our Alcohol and Drugs Partnership colleagues and are now have areas that we're picking up directly into ED and then within medicine unscheduled care. So for example, what would normally have happened is people who were coming in frequently to ED that were maybe under influence of alcohol and influence of illicit drugs, so using there, they would not be picked up until maybe they'd hit a further crisis point down in their journey. Now, what's happened, we've got navigators that are in at the front door that are working with our colleagues in key areas such as the weekend. We've invested in drug and alcohol nurses at the front door. From a Musk perspective, we analysed, are we better to deal with, have that resource with an ill health model, or are we better to use it in a prevention? We've moved it through into prevention, so it's at the front door, and now what's happening is we're picking up people before they're known to services, making early contact through our navigators, making referrals through our ADP nurses, and really helping to tackle that. And I suppose that's one example of, yes, we're definitely being data-led as to where we can do that. Often another example would be during the, and Susan I'm sure would be more eloquent on this than I, but one example is that during the peak that we had within ED, for example, then that has a knock-on effect on Paul's portfolio through orthopaedics and all of that. From the winter period in the falls, we did a postcode analysis on there and found out that there were some areas whereby we weren't having as much, it was a high level of falls, so we worked with our local authorities to get gritting in place to therefore help those vulnerable. And I know that's might be saying that's not hard to reach voices, but I suppose we just use the data to highlight the issues to then start to move forward. Does that answer, does that help Luann to give assurance? But very much, I would say that we are data-led.
Thanks, Sandra. Yeah, it's really helpful to hear that. My ask would be, obviously these reports are developing, but it would be really helpful to have that type of information in our usual, in these reports in future, because I think that's a really important areas of work. Thank you.
Thanks for that feedback, Luann. Susan, you put your hand up there. Do you want to contribute to that, or?
Yeah, just to add to Sandra's comment, because the team not only worked with local authority colleagues, but also community councils. There was analysis done around vulnerability, and we're doing a community-led pilot around gritting pavements in some of the areas where there was a greater number of falls. So some of the actions we're taking took a little bit of time to engage with communities, but we hope these will be in place for this coming winter. Thanks.
Thanks, Susan. Thank you. Dennis, please.
Thank you, Chair, and thanks, Sandra, for your report. One of the challenges in achieving some of the aspirational goals that we have is around workforce, and perhaps that resource, and it probably cuts across most portfolios, to be honest. But in terms of the preventative measures that we're looking at, how challenging is the fact that maybe we don't have the resource in terms of workforce that we actually require, and what steps are being taken at the moment in working collaboratively, say, with our college, universities, schools, etc., in actually trying to attract the workforce for the future. Thank you.
Thanks, Dennis. Caroline put a hand up there. Caroline, will you like to answer that question?
Yeah, because I think it's a massive question, Dennis, a really important question, but it's huge. And so from my perspective, your comment about it affects every portfolio, absolutely correct. And so there's a multitude of things. I'm keen that we could hear a little bit from Jane Ewan, who's deputising for June Brown today, because she's around things like academies and also the work that we're doing to develop interest in working in health and care. So there might be something Jane wants to say, and I'm absolutely convinced Tom will have comments. I think from my perspective, one of the things that we are working through, however, is that it's not necessarily just about financial resource. And of course, we will always be we're a public sector organisation. We are always going to be able to do more if we have more funds available to us. However, equally as important to that, and I'll use the work that Paul Baku's been doing around planned care, equally as important to the amount of money that we get is the pattern in which we get it. So our belief, and again, I've got Alan and Paul to correct me if I make a statement that's not accurate. Our belief is that with the same money that we get annually, if we were to receive it on a recurring basis and in a planned way, our ability to plan services, to grow our core workforce and to develop a sustainable workforce would be much greater. So I don't want the message to be taken from this comment is that we don't need more financial resource. Of course, we are constrained. However, we believe we could be much more effective if the pattern of that funding was different, as well as all of the other additional work that's going on with colleges, schools, partners around growing our workforce. So hopefully that's helpful, Dennis, in a kind of overarching statement about our work.
Well, just bring in June, because she put her hand up as well. June, did you want to add something? Sorry, Jane. Sorry, it's my eyesight here on the screen. Jane.
Thank you, Chair. Yes, just building on what Caroline is saying there. We're doing extensive work as part of our anchor organisation approaches with schools and with colleges, and that's both within primary and secondary curriculum. So really looking at healthcare being aligned to the curriculum to make it much more real and vocational, whilst developing a partnership with particular secondary schools through various foundations to bring young people into the workplace in a variety of opportunities, whether short and long term. We have our work experience policy that has been reactivated since COVID. So we're hoping that over the summer months and as we go into the new term, then that will open up much more opportunities for young people at different levels. And we're looking at simulation in a much broader context in conjunction with our NHS Academy work and NHS education, which will make that much more live for young people across all disciplines within healthcare as well. Continuation of recruitment fairs and in-house simulation, both within schools and colleges, will continue as well. And I think in reference to our university colleagues and students, with Robert Gordon University being our main partner, we are doing really quite close work to try and align our undergraduate student nurses and midwives in their final component of their undergraduate programme to really consider where they would like to take up their first role as a new graduate and try and align placement and support pathways appropriately that will support the recruitment but also the retention of that group of individuals. Recognising that they've had an altered experience in their undergraduate programme, so support is absolutely crucial from practice education and ensuring retention of that workforce and sustainability.
Thank you, Jane. Thank you. And Tom, you were going to add something as well?
Yeah, thanks, Chair. And I'll try not to duplicate what Jane said, because she's given a really good overview there, actually, of the ways in which we're widening access to health and care careers and using a whole range of initiatives to support that. I think, you know, we've got to be really mindful in the work we do in the NHS space of the potential impact that can have more broadly, particularly in terms of roles in social care. So I think when we connect through groups like Aberdeen Prospers as part of the community planning partnership approach in Aberdeen, for example, to understand what's going on across the patch, not just and share what we're doing in health, but also think about what others are doing. That's really important to just getting a sense of I guess where the pressure points are, and I think it's definitely important that work continues nationally and locally on strengthening the social care offer as well, because clearly there needs to be some balance there. We are exploring, though, at the same time, where there is and maybe need for scope for recruitment and retention premia in relation to particularly challenging areas, roles to fill in our system, where there's, say, a combination of economic factors and scarcity of supply that may make that something that needs to be pursued. But they're exceptional measures rather than something to be relied on as the norm. I think the other things to highlight, I suppose, are that looking forward to the longer term, we're about to resume or get started on sort of joint workforce planning forum with colleagues at Aberdeen University, which will be really helpful to be able to tap into some of that broader expertise in support of our longer term planning. And with NHS Education and others, we're looking at, I guess, workforce diversification too. So what are the kind of roles that we need moving forward? And that's not just based on, I guess, skills that we require, but also some of the limitations on supply that we experience as a system that is part of an international market where, you know, there are scarcities that we have to deal with as well. So there's a lot of longer term work going on there, as well as the stuff that's happening in the here and now that Jane was described really well.
Thank you, Tom. Dennis, you assured by those answers there?
I am indeed, Chair. Thank you.
Thank you. Thank you. And Sandra, I think, thanks very much for staying. Probably a bit longer than you expected to stay then, but thank you very much. We'll let you go now, and we'll turn to the rest of the report that we have in front of us as well. There's other areas as well. So thanks, Sandra, for your contribution there and your answers. Comments or questions about the rest of the report, please? Thank you. Derek.
Thanks, Alison. Just a couple of comments, really. I thought it was very good to see the green spotlights. It's important, I think, to understand what's going well as what's not going so well. So I think that was a good addition. And the second one is a little bit about language. On page 31 of the voice of our citizens via care opinion, the vast bulk of the comments are classed as non-critical. But if you go into the box, it says non-critical bracket or positive bracket. And to me, positive sounds a damn sight better than non-critical. And I wondered if maybe we want to use that word as opposed to non-critical. I understand that some of the maybe neutral comments, but positive just sounds so much better. Thank you.
Yeah, thank you, Derek. That's important feedback as well. I think we'll reflect on that when the paper's produced in future as well. So thanks for that comment. Thank you. Luann, please.
Thank you. Two questions or bits of feedback from me. One was on the system leadership development work. And I did notice Tom mentioned earlier about conversations around the importance of upstream activity and focusing on that. I just wondered, thinking about the future, and well, have there been discussions around the leadership development sessions about what new skills our leaders need to help them connect more with the inequalities agenda, get out and connect with communities more directly? You know, is that in the mix for how we develop our leaders? Because I think if we're really genuinely going to do things differently, we do need to skill up our existing colleagues to be able to engage differently and really understand how health inequalities is part of everyone's role. So that's my first question.
Thank you, Luann. Tom, do you want to take that?
Yes, I can do. Thanks, Chair. And Luan, can I just check, is that within the bit around building system leadership capability that you're referring to?
Yes, Tom. Yeah, that's right. Yeah.
So I guess within, it's not explicitly within, I guess, the work that has been done with the King's Fund, other than that, I guess the King's Fund work is designed to encourage thinking about the whole system and all, you know, beyond the, I guess, the formal kind of organizational boundaries that we have, you know, working within our, I guess, within our buildings and our you know, our premises, etc., and actually interacting and being part of a wider community and system. I think in terms of things like how to actually approach the issue of inequalities, etc., it's not, the program isn't really around teaching people in that respect. So but I think it's a fair point that you make, and maybe something we need to look at through the lens of what's on offer through the national programs that NES and others provide, for example, and whether there's content there that we would be happy would meet that requirement, and also to think whether we can use some of the year of the manager focus we have over the next 12 months just to build in a bit more explicit focus on that. So I guess the answer is it's not really explicitly referenced within the system leadership work that we've done with the King's Fund, but neither is it kind of, you know, not considered at all. But I think if we wanted to equip people to be able to engage in particular ways around that, then we'll need to look at things like year of the manager, and as I say, the national offers, just to see what scope they provide us with. So thanks for that. It's a useful one to take away and have a look at.
Thanks, Tom. I think Susan wants to come in as well. Susan?
Yeah, and it's just to confirm that this was identified as an area for development in the Health Inequalities Action Plan that was approved by the board. I guess part of the initial work in the first quarter is understanding what maybe gets in the way. Again, we have had feedback that when the system is so under pressure that individuals are responding, and it is about how we work with them to create that capacity about the early intervention, prevention, looking at the whole person. We have got a number of tools from elsewhere, but again, we need to work with GAPF, Tom's team and others around what is the best way of taking these forward, what are the most appropriate ones. And then finally, we hope that by introducing systematically the impact assess screens and looking at the requirements of the Fairer Scotland duty, that will then begin to, I guess, learn by doing and help create different types of conversations in our system. So I hope that goes part way to answer your question.
Thanks, Susan. So back to Luann now for that.
Thanks, Tom and Susan. Yeah, I mean, I suppose there could be learning and skills and knowledge, but there's also practical things. We talk about being a whole system. So how are we connecting with our community planning partners and going out and seeing where people live and understanding the real barriers that people face? That would be part of the development that I'd be looking for in the future for our leaders. But really helpful, and appreciate your feedback there. My second question, Alison, if that's okay, is on a totally different point, on page 39 on the cancer performance. It says that we haven't met the targets, but there's been no harm caused to people as a result of that. There's been quite a lot of analysis of that. I suppose I'm reading that as harm in terms of physical harm. There's no increased mortality, but I think we can't ignore the psychological harm that may be caused to people by sitting on a waiting for cancer treatment. I imagine that's really distressing for people and families. So I just wanted to hear, what are we doing to support people whilst they're waiting for cancer treatment, and their families as well? Hopefully maybe Paul can answer that. Thank you.
Thanks, Luann, for that question. I'll turn to Paul, please. Paul.
And the question, and I think some of the answer, or not the answer, some of the response from me will hopefully touch on some of the issues that Caroline brought up earlier on around how we get our funding to develop our service. So there will be a link. Firstly, I think it's absolutely right. What we're talking about support is a very crude endpoint, mortality, and we all agree that that is not the best quality quality of life measurement, clearly. All right, so we absolutely agree it's the wrong measurement. What we are looking at is a range of interventions that have been introduced over the last 2 to 3 years, and many of them were funded through non-core funding. In fact, all of them have been funded through non-core funding, and whether it's voluntary, the third sector funding it, or whether it's us making space for these services through the non-recurring annual access performance money we get are variable. So there's a real issue around how we get funding to do that. And the type of work that we've been doing, 2 years ago, we had support from the Macmillan Foundation, and we employed a point of contact, a clinical nurse specialists, who were able to make contact as a specific named person for everybody who entered one of the 13 cancer pathways. So that services now are coming up to 3 years of age. And at the time, last year when we audited it, the figures off the top of my head were that in a 6-month period, 7,400 contacts were made for that service. 85% of those contacts were around clinical issues. So there's a navigation system that we've had in place. Since then, we've also now introduced healthcare support workers to take some of that demand away from our clinical nurse specialist team and deal with it. So they're the two things that have been established the longest. We've also now got a navigator service. I'm just reading my sort of detail there. So a navigator service that signposts to the third sector. And more recently still, we've got collaboration with primary care to roll out Improving Cancer Journey across the NHS Grampian, which helps to provide the non-clinical holistic navigation systems to things like money and time for people who are on these cancer pathways. We're working with Maggie's for the prehabilitation service, and part of the prehabilitation service is a psychological support service. We've also now funded a clinical psychology post specifically for the cancer pathway. But all of these things that are being described are all things that the teams that look after our patients and citizens have identified. The funding continues to come from service, from areas that are not part of our, reliable, sustainable funding streams. So there is that big issue that we continue to face. And it is also an interesting thing that we're now discovering is quantifying the impact of many of these services isn't quite so simple as counting the number of patients you put through an operating theatre or a clinic. So understanding how we quantify and have that conversation about their value in a way that makes sense to people that control funding streams is in itself one of those new emerging challenges. But I hope that sort of helps some assurance.
Thank you, Paul. I think that point that both you and Caroline have made about the impact of how we get our finance and the impact that has, I think has been well made by both of you, and it's an important point for us to be aware of moving forward and to make that point elsewhere as well. So thank you for that. Luann, are you assured by those answers?
Yeah, thank you. Really helpful to hear that. And I think as we develop these reports, again, it would be good to see more of that quality of life indicators, referenced rather than just the sort of the more extreme measures, because that really matters for people, how they experience care while they're waiting. Thank you.
Thank you, Luann. Joyce, please.
Thank you. Yeah, Paul, I was interested in seeing the learning in that spotlight, which deals with the capacity, which you've just spoken about in terms of money. And I know that there's the North East Cancer Alliance, but is there also a national group that can help us to lobby Scottish Government because if funding with us is insufficient for the cancer pathway that we're trying to design for the future, I presume that it is similar in other health boards as well, and working together would ideally be better than all working separately to achieve that. And then secondly, you've spoken about separating out cancer. So will there be some activity from this to look at the possibility of that, what the implications are, what the benefits would be in the future? Thanks.
Yeah, thank you. Absolutely. So the first question around almost sort of how to organise ourselves better is definitely happening. It's happening through lots of routes. The conversation that Caroline has with her senior government team, the conversation that we have as a site in the region, and regions coming together, they're all happening. Conversations that Nick has as a medical director with other medical directors are all occurring. So all of those sort of separate areas are becoming much more joined up and connected to this. And the recent conversation that we had as part of that sponsorship visit very much laboured, I suspect, as far as they're concerned, the point that to develop sustainable deliverable services that grow with changing demands and profiles, you need to be able to flex and adapt, and you can't do that unless you've got core funding. So there are a number of routes for that coming through, and we'll continue to press that point absolutely over the next 3 to 5 years. And in fairness, some of the feedback already from Scottish Government demonstrates that next year in 24-25 there will be a transmission, if you like, of funding from non-core to core, as opposed to the annual non-recurring money. So they have started that journey in fairness, and hopefully it will continue. So that hopefully, Joyce, is your first question. And of course, going on at speed, I've forgotten your second question. Could you remind me, please?
Yes, it was about the second part of the learning about separating cancer out, and what the implications would be for doing that.
Yeah, and so I think it is the intent over time to really look at how best to organise the provision of healthcare, certainly in the secondary setting, and the big things that we're all looking at is your planned chronic care, your specialist care, and your unscheduled care. And within planned care, cancer and non-cancer are absolutely, the pathways are just knocking into one another multiple times. You only have to look at the work that's been done by the breach analysis of our 13 cancer pathways. All of our cancer pathways, every person in a cancer pathway is inevitably being blocked at some key points which are common to lots of other pathways. Now, we do need to work out how we square up the cost effectiveness and the size issue of separating these services. But until we do that, I think it's going to be very difficult to ensure that everybody goes through the same pathway using the same bits at different times, but at speed. It's just not possible. So we are going to have to separate our cancer from our non-cancer, from our planned from our unplanned, from our acute from our chronic. But that's clearly it's a bit of a journey that we need to go on. And I think the first thing is to separate core from non-core funding and make sure that we have sustainable services to build on. Thanks, Joyce.
Thank you, Paul. Joyce, are you assured by that?
Yeah, thank you very much for that, and I look forward to hearing about any progress in that over the next year or so. Thank you.
Thank you, Paul. I was going to ask a question about regional working as a response to the challenges that were faced, in particular in cancer, but I think you've given an answer towards that as well by talking about the engagement you have with other people across the piece. So thanks for that. I can't see any other indications of questions or comments on this paper. So we were asked in the recommendations to review and comment. Actually, Joyce, is that you coming back again?
Yeah, but Amy was in before me.
Okay, Amy, sorry, Amy.
Yeah, just briefly. Hi, morning, everyone. I think that the separation stuff is really interesting. I'm just wondering, because a lot of patients say to us, we want more holistic care that deals with my long-term conditions, and also I've got cancer. So I'm just wondering, how will we mitigate against overly separating people's body parts, if you like, when we come to treat them?
Yeah, no, just on that part, Amy, I think you're absolutely right. I think the number of connections between different pathways for any one person is enormous. It really is. You know, there's those diagrams that the King's Fund do about 5 people in a room having all sorts of connections. So it is. I think we need to set a certain level at where you analyze and organize a pathway. But we're not going to be able to separate it separately. And we know that in our current climate, with our current demographics, people have at least 5 different diagnostic codes when they enter hospital. It's not one diagnostic code. So we will have to take that into account, and there will definitely be overlaps. But I think currently the overlap is too much in the way that we set our services up.
Thank you. Amy, you sure about that?
Thank you. Yes.
Thank you. Thank you. And Joyce, please, Joyce.
Sorry, yeah, I have another question, and it's about the reduction in supplementary staffing. And I was wondering if we're now really at the time where we should be changing our assumptions, because younger generations have different ways they want to work. People have a different view of work-life balance, and we're making assumptions that we still want to have lots of people working full-time as the word I'm looking for, permanent employees of NHS Grampian, where people really want to work part-time. They want to have different jobs. They may want to have a few different jobs to give them variety in their life. So possibly it's time for us to change our assumptions and accept the fact that we're going to have this level of expense to get the staffing that we want. But if we accept it, then we may be able to provide a better base for people to be more flexible in the way that they work with us. And over the long term, we have more reliable staffing, although it's of a different format. So I think possibly it's time for that conversation. And I wondered if anybody else agreed with that or didn't, indeed.
And it's also part of a contribution to us as an anchor organisation, providing different employment opportunities as well, I think, as part of that too. So Tom, I think, would be best for that one.
Thanks, Chair. Thanks, Joyce. So I guess there's a few things in that. One is obviously recognising the generational differences, as you've said, Joyce, that, you know, in terms of people's expectations around work and work-life balance, etc. And I think some of the agenda for change pay reforms are designed to kind of try and move things on a little bit in respect to that, in terms of, you know, the work amount of the length of time in the working week, protected time for learning, etc. The introduction of the e-rostering software is also designed to try and support more flexible, I guess, allocation of time and you know, people to time and support a bit of self-service. And actually our bank arrangements give quite a lot of flexibility to colleagues. And I think as part of a supplementary staffing makeup, they offer probably quite a good value approach to doing things. It's when we have to use high cost external agency staff that really drives up the cost. So we are looking at work, for example, to develop and implement a medical staff bank to sit alongside our MMAP bank. Both having those two things in place would be the preface to have a single staff bank for Grampian that would give, hopefully, you know, support people in working and staying to do supplementary work locally, rather than the needing to go elsewhere, if you like, to find sort of shift patterns and things that work for them. I think there is a broader conversation and piece of work that does need to be done to look at kind of what is the construct of time, you know, how is time chunked up in our system, and how does that kind of, you know, how can that be done in a way that does enable more flexible approaches to work for substantive colleagues, not just those who want to access the bank. But as I say, if we have that's a longer term journey. I think that probably, you know, I'd probably welcome both Nick and Jane's thoughts on that, because it would take quite a while to work its way through. But I think in the meantime, having a good and effective bank arrangements can mitigate the real drivers of high cost in supplementary staffing, which is agency use, and also provide some greater flexibility for colleagues around, you know, say working hours that suit them rather than just a fixed shift pattern. So hope that answers the question for now. No easy answers to it, but it's definitely something we need to attend to. But I don't know if Nick or Jane have got views they wanted to share on that, or even insights from their own professional groups.
Would either Nick or Jane like to come in?
Yeah, I'd love to come in, Chair. So I think it's a really important question, Joyce, because you know, it is absolutely the case. What work people want to do and how they want to work is actually definitely generationally changing, and we don't understand it as well as we could. We know data from doctors in training, for example, data from even a few years back for all doctors training to be GPs, 90%, just under 90% wish to work less than full time. We know that the junior doctors who are qualifying now, who go into training schemes, around 40% of them will step outside of the national training schemes to do standalone work for a whole variety of reasons. But it tells you that the structural offering that we have in terms of taking people from medical school through to the traditional endpoints of consultant or general practitioner are definitely not fitting the needs that a large number of people have. People are also looking about the length of their service and how they run portfolio careers, how they do all these things. So Tom's alluded to some of the mechanisms of, I guess, offering flexible engagement. And alongside that, I think we need to do a whole heap more work about what do people want out of that career profile in terms of how that's structured. And that involves engagement with NES, and certainly as medical directors, we've in fact had our annual general meeting where it had a very good dialogue about, you know, how the training offering needs to potentially be modified to start sort of taking account of really what are the desires of people who are, you know, generations below, younger than me, in terms of how they want to work, because they're probably going to have to work longer in a different way, in a different setup. So I think it's a really, really important question, and we absolutely don't have all the answers. But some of these systems Tom describes are very helpful to sort of give some flexibility for people.
Thank you. And Jane?
Yeah, I think just echoing exactly as Nick is saying, and we're seeing a rise in the number of nurses and midwives that are choosing part-time opportunities. The retire and return policy, we're seeing more staff that are looking towards doing that. And I think as an organisation, we need to continue to work with the experienced, knowledgeable individuals to look at how we can support them back into the service. And yes, that younger generational shift, Generation Z, are looking for completely different views on work-life balance, and we need to be responsive to that as an organisation.
Thanks, Jane. Thanks, Jane. Batty, you coming on this?
Yeah, thanks very much. And just to agree with what we've just heard and reiterate the point that this needs much more involved, detailed discussion. And I know Tom has some thoughts about this, because workforce planning for the future genuinely needs to start with the future rather than plan for the workforce in the image of what we've had in the past. And that needs imagination and flexibility from a number of stakeholders. And Nick is absolutely right to point out the key role that NES has. And we've had recent conversations with NES where we found them to be much more accepting of a different route for planning workforce, particularly for medics, which was the focus of that conversation. But there are other key players here as well, including the Royal Colleges, which have their own views on how people should be trained to be ultra specialists, as it were. So I think that there's quite a lot here to discuss, but this is a good start, I think, to flag this up as a key area of concern.
Thank you. That's a real key point you made there about thinking about the future rather than basing what we're doing on what's been in the past. That's a key point there as well. Tom, just to finish off this bit of discussion.
Yeah, just I mean, all very valid and helpful inputs from colleagues. And I guess the one thing I was holding in my head was that in looking at our update of our progress against our workforce plan ambitions and looking at the data related to that, for the first time, I think we've just moved to over half of our colleagues actually working as being part-time employees rather than full-time employees. So I think in amongst all of this, we do actually offer part-time opportunities for a lot of colleagues already, and they're able to take that up. So we're starting from, I guess, being an organisation that engages with that sort of thing. But it does also present us with some challenges, because as we and not just in a clinical workforce, but more broadly, we see that for the number of people we need to actually cover the same, well, provide the same amount of capacity has increased as a result. So the number of individuals you need who have been trained or who have developed the knowledge and skills to be able to perform the functions you need them to obviously increases the more of those who are working part-time. So in pursuing those aims and looking to, I guess, make careers as attractive as possible for people, we in the shorter term will have to deal with some capacity challenges that presents for us as well. But it doesn't mean it's the wrong thing to do, because long term, hopefully, it attracts and retains more people.
Thanks, Tom. Joyce, I'll come back to you for any final comments.
I'm grateful to hear that there's discussions going on about this, because I think it's absolutely vital, and I think it needs to be included in our budgeting as well, so that our budgeting doesn't stick to the sort of the old way of doing things, but looks at a different future. Thanks.
Thanks, Joyce. Thank you. And I'm saying cautiously this time, I can't see any indications coming forward to say anything on this paper. So we'll move to recommendations to review and comment on the performance data and confirm that the report has provided sufficient detail and assurance about performance. Can we agree those recommendations, please?
Agreed.
Agreed. Thank you very much. And moving on to paper 7, the year-end financial position. Alan Sharp is going to lead us through this paper. So turn to Alan, please.
Thank you, Chair, and good morning, everyone. The report you have gives an update on the year-end financial position for 22-23 for NHS Grampian. I'm pleased to say that NHS Grampian achieved each of the 3 key financial targets for the year. That is, we operated within the revenue resource limit, we operated within the capital resource limit, and we operated within our cash target. Each of these is subject to external audit, which is taking place at the moment. On the revenue position, we are reporting a small underspend of £0.6 million. The revenue position improved significantly in March, and this was because we received funding from the Scottish Government to meet a number of Grampian-specific system pressures. We were also able to reduce the accrual that we make for untaken annual leave, as staff used up leave balances that were carried forward at the end of the last financial year as a result of the COVID pandemic. Even though the board achieved a balanced outturn in financial year 2022-2023, the underlying financial challenge for NHS Grampian continues. The board were updated on our financial plan for 2023-24 at the April meeting, which projects a gap for the year of £60 million. The gap is driven by multiple factors. However, inflationary pressures are undoubtedly a significant contributor to the overall financial challenge, not least within the areas of costs for energy, drugs, and medical supplies. Balance was also achieved in 2022-23 using a number of one-off measures which will not be available in the current financial year. We do have a local value and sustainability group which is taking forward the delivery of our efficiency programme for the year. However, even with full delivery of our planned 3% savings for the year, it's likely that we will not be able to achieve a revenue break-even position, and it looks likely that we will overspend against our revenue budget for 23-24. Finally, I'd just like to draw your attention to the infrastructure investment programme for 2022-23, which managed to invest £108 million in new buildings, equipment and IT systems. I think this is a record total for Grampian, and a large proportion was spent on the bed and anchor project. Thanks must go to all asset managers and other staff who work so hard to achieve the programme. That concludes the finance update, but I'll be happy to answer any questions on it. Thank you.
Thanks, thanks for that update and showing the position we're in at the moment for finance. Any questions or comments on the paper, please? Derek, please.
Thanks, Alison. One very quick one. A very small underspend, 0.6 million out of 1.4 billion. But are you allowed to carry that forward into next year?
Yes.
Alan?
Thank you.
Yeah, all right, thank you. Thank you. Straight up forward answer there. Dennis, please.
Thank you. I'll be very quick. In terms of, you mentioned the cost of drugs as being a significant factor here. Is there a national conversation being held in terms of working with the drug companies to find a way of trying to ensure that, I don't know if it's the bulk buying or whatever in terms of across the board from maybe a Scottish perspective, but some way of trying to reduce or the cost of drugs that each health board is actually incurring at the moment? Thank you.
Alan, please.
Thanks, Dennis. I think there are lots of national conversations ongoing for drug costs, both at a UK level and a Scotland level as well. There is a national UK-wide scheme which regulates the costs of some very high-cost hospital drugs, and that's currently being reviewed at a UK level by the Westminster government, who are in negotiations with the pharmaceutical companies around that. So we await to see what the outcome of that will be. We and other Scottish health boards benefit out of that at the moment. There are also big pressures on our drug costs around primary care prescribing, the drugs which GPs prescribe at the moment, and they particularly impact on our health and social care partnerships. A lot of that is just down to the inflationary pressures of the cost of raw materials and labour, which has gone up across the world, not helped by things like the conflicts in Ukraine. So there are discussions ongoing, but there's still a lot of upward pressure on our drug costs at the moment, Dennis.
Thank you, Alan. Amy, please.
Thanks, Chair. Thanks, Alan and the team for this. It's a really helpful read, if not an easy one, I think, with all the challenges and the figures in there. I'm just wondering, with return to having a conversation with our community around, what we can and can't do. Would this be an opportunity to speak to people from our patient involvement network to kind of see what they feel about this, to see how can we have this conversation with our wider community and to sort of test it out in a safe space? Would that be a good idea?
Alan, would you like to answer that? Yeah.
Yes, thank you, Chair. Yeah, thanks for the question, Amy. It's an important issue that you raise, because we do try and be transparent about our financial position and the challenges that we face as a board and how we prioritise things as a board. So happy to take that forward with you out with the meeting. But yeah, involving the public and our patient information network would be a good thing.
Thank you. I'll bring John in first for his question. I'll come to Caroline at the end, I think, to pick anything up. John, please.
Thank you, Alison. Yes, just to get clarity on this. So we avoid brokerage this year. We have one-off fixes that have come in, which is sort of embedding the bit that is against what we want in terms of planned core funding, which is recurring. So it's welcome to have that fix, but we've got a £60 million underlying pressure here, and one that's kind of building. So I suppose whilst welcoming this, we still need to work out how we're going to get hold of that underlying pressure. Is that correct? Just want to. I think that's how I'm reading it, and so we've still got to find savings as we go forward, although we know that we're we're a bit short of funding going forward. So I'm just trying to think where we might be by this time next year, and we can't obviously just rely on fixes coming in. So as a board, we need to plan around that 60 million is my question.
Yeah, I think that's a very fair synopsis of the situation at the moment. John, I'll pass to Alan though. Alan.
Yes, John, I couldn't have put it better myself. You've hit the nail on the head there. So we achieved financial balance in 2022-23 using a variety of measures, but a lot of them were non-recurring and will not be available to us in 2023-24. The financial plan that was presented to the last meeting of the board hasn't changed significantly since April, and so we are still looking at a reasonably significant deficit this financial year.
Yeah, and there's a task there for us all going into the future, isn't there? Thank you. Caroline.
Thanks, Chair, and thanks, Alan, for the paper and colleagues for the questions. I think this, for us as a board, is the financial position is an absolutely critical context for decision making for us going forward. And you've highlighted the challenges, the opportunity to have the 3-year plan that Alan and colleagues have worked through with Scottish Government, and our 5-year plan to recognise that for a number of years our financial position is not going to be balanced. And that requires us, I think, to think about the longer term and to be really clear and transparent, right, to Amy's point, with the public about why and how we are making our decisions going forward. So I think the decision-making context for the board is going to have to change in relation to how we do that. However, the specific point I wanted to make was clearly the health board is not the only public sector part of the system that is challenged. So we have the IJBs and we have our local authorities. And at the beginning of this meeting, we discussed and described the critical interdependencies of how we work. And therefore, to just applaud really the joint working that is going on between predominantly our finance officers across those organisations, but with many others, to try and identify that savings in one part of the system do not have an unintended consequence on another. Undoubtedly, there will be consequences. So at the moment, we are having preliminary conversations around how do we manage that risk going forward, and how do we have a shared understanding of the consequences. So Dennis, I think that goes back to your earlier point about whole system, and my response around where we can make efficiencies and where we can understand that. So today you're obviously seeing NHS Grampian's financial position. And that's really important. And in the work and in the round, we take that in the context of public sector in Grampian and are working really closely to do our best with what we've got in the north. Alan, would that be fair comment?
Yeah, yes, absolutely, Caroline. We had a meeting of senior finance officers last week with some council and other public sector colleagues to make sure that none of us were cost shifting essentially between different parts of the public sector.
Thanks.
Yeah, thank you both, Alan and Caroline, for the clarity there. Obviously, the challenges are well set out for us to face, and the context for our decision making going forward, and the need to do things differently as well in order to sustain services as best we can going forward is all clear in the paper set there in front of us. So thank you for that, and thank you for the questions as well. I can't see any other indications to speak there. So on this paper, we're asked to review the information provided and confirm that we are assured that we've achieved the 3 key financial targets for the 22-23 financial year. Can we agree that recommendation, please?
Agreed.
Yeah. Thank you very much, colleagues. Moving on then to item 8, the Forum and Integration Joint Board reports. First of all, the Area Clinical Forum. Kim, your last chance. Kim, your final meeting here, and again, I reiterate the thanks to you as made at the beginning as well. Kim, would you like to introduce your paper, please?
Yes, thank you. Yeah, I'd be quite brief. Most of our conversation at the last area clinical forum meeting was again around challenges around staffing, particular notes of paediatric anaesthetic, dentistry, general practice, and to be honest, most other disciplines, but I don't think that's any surprise to anyone. So just a fair bit of conversation around the challenges there. But what is good on the positive of that is that the GAPF and ACF group on staff breaks, rest and recovery is making some progress. So that's something that's good and positive, and will hopefully have a positive outcome for staff. I think the only other thing that I'd have to say is, of course, the process for my replacement is well underway. I'm confident we'll have an excellent candidate in place. So there's no sort of drop in ACF chair, and but I just can't say who that is yet. But I just really wanted to thank the board for being so welcoming and supportive throughout my term, and I'm really going to miss this. But thank you, everyone, and I'm happy to take any questions.
Thank you, Kim. We'll miss you too. Thank you for all you've done again. But a question from Dennis, please. Dennis.
Thank you very much, Chair. I'll be brief. Kim, again, just to express our sincere thanks to you. You've been an extremely good colleague and supportive, certainly for me, during my time. A quick question. You raised the issue there, paediatrics and anaesthetics. I just wonder if, in put this in context, this is also being looked at through clinical governance, for instance, and progress is being made. It just seemed that it was there, but there didn't seem to be much in terms of the narrative around it as to what else was happening in the system. Thank you.
Thank you. I think Geraldine put her hand up. I'll just bring Geraldine first on that one, please. Geraldine.
Yes, thanks, Chair, and thanks, Dennis, for the question. Happy just to come in with some more information on that. So, yes, there was an update given to the Clinical Governance Committee at the last meeting, and details of the steps that are being put in place to mitigate the risks. So there has been a considerable amount of work done recently, and obviously discussions being led through the adult anaesthesia team, where the paediatric anaesthesia team sits, and we are in discussions in terms of the cover and availability of skilled staff. So that work is very much ongoing. And in terms of that assurance piece, the Clinical Governance Committee were happy that we continue to bring an update through the CRM report to the next meeting, but happy to give any further details as needed.
Thank you for that, Geraldine. Thank you. Simon?
Just wonder, Chair, if I can just mention primary care, because that's come up in a number of forums as a concern about the kind of longer term sustainability and resilience of primary care, including in this meeting that we're talking about. So primary care, we've got our primary care colleagues who've been working collectively across the 3 partnership areas on looking at how we can build resilience and sustainability and what the longer term future could look like. We have a workshop being delivered by our GP clinical leads across the 3 partnerships for the Chief Exec team, and we'll be working together with them on the 9th of June. We have a shared objective for the 3 chief officers because primary care development is devolved to the IJB. So there's a shared objective for the 3 chief officers around how we build a primary care strategy and implementation plan in this year that addresses those longer term sustainability issues. Thank you, Chair.
Thank you for that, Simon. Thank you. Kim, final word on your paper, anything to add?
Nope, nothing further to add. Thank you.
Brilliant. Thank you very much. And thanks again for your work for that one. Can we note the Erican forum paper then, please? Thank you.
Noted.
Paper noted. Then turn to 8.2, the Grampian Area Partnership Forum. Stephen, please.
Thank you, Chair. Colleagues, I'll keep this even briefer than Kim's report. You've got the paper which indicates the items discussed and considered by GAPF at its meeting in May. I guess the only update of note is in terms of the Industrial Action Short-Life Working Group. That group's work continues, and we await with keen interest the outcome of the member consultation that's currently underway or begins on Monday the 5th of June and is due to end on Monday the 12th of June. Regarding the junior doctors pay offer. So I guess watch this space. Any questions? Thank you. Chair.
Thank you for that update, Stephen. Any questions or comments for Stephen, please? No. Can we note the Grampian Area Partnership Forum paper then, please? Thank you. Paper noted. And then 8.3, the Integration Joint Board report. Obviously, we've got Sandra, Pam and Simon all here. Well, not Sandra anymore. Pam and Simon. Any points to make on this paper?
I just wanted, I guess, to again highlight the breadth of business that the IJBs are carrying out, and I suppose through the lens of system leadership and system working, we can start to look more and more at the work IJBs are doing in that perspective. There's a time lag always between the approved minutes and being able to provide a solid summary to this board. So the links are there for each IJB so that people can see the latest meeting papers. There've been subsequent meetings in most cases along for each IJB. I think as well that the way the meetings are timed differently for each IJB, it often looks like there's very different business being carried out, but I think over the course of the year you can see the similarity in terms of the issues that IJBs are tackling in each of their areas. Thank you, Chair.
Yeah, thank you, Simon. That's very helpful. I can't see anyone indicating on this paper. No, so can we note the Integration Joint Board paper as well, please, then? Thank you, that paper's noted. And then we turn to item 9, the approved committee forum and IJB minutes, just to go through and note. We have, first of all, the Audit and Risk Committee of the 14th of March 2023. Just please indicate in the chat if you want to make any comments about these papers. No. The Endowment Committee of the 27th of January 23. Luann?
Thanks, Alison. But just to note, reading the minute reminded me we had a wonderful launch of the NHS Grampian charity in March. So just for, I think everyone's probably aware that it's now rebranded and is called the NHS Grampian charity. So I would expect, I'm just checking, but in future we would be calling we wouldn't be calling it the Endowment Committee, but the NHS Grampian Charity Committee for future board papers.
Chair, if I can come in
Dennis,
here.
yes, I was going to say, Dennis, come in.
We actually had this discussion, and apparently we've got to continue to use the endowments, although the rebranding is NHS Charities for obviously all the funding streams that come in. But constitutionally, we've actually got to continue to use the endowment. We are looking at ways of trying to align it so we remain NHS Charities rather than endowments, because it is adding some confusion, but it has to remain endowments for the moment. Thank you.
Thank you for that, Dennis and Luann, and take the opportunity of asking everybody to promote NHS Charities as well and the wonderful work it's able to do. Thank you. Next paper is the Performance Assurance Finance and Infrastructure paper, 22nd of February 23. No indications, thank you. And the Staff Governance Committee of the 24th of February 23. Thank you. The Clinical Governance Committee, 21st of February 23. And the Population Health Committee of the 23rd of February 23. Okay, I can't see any indications on any of those. So all those papers then we will take as noted. And then the forums, we have the 9.7, the Area Clinical Forum of 1st of March 23. And the Grampian Area Partnership Forum of the 16th of March 23. Okay, so both those papers also noted. The Integration Joint Boards papers, Aberdeen City IJB 31st of January 23. Aberdeenshire IJB 1st and the 29th of March 23. And the Murray IJB of the 26th of January 23. Can't see any indications on those papers, so they are all noted as well. That takes us on to item 10 then. Any other business? Is there any other business for this meeting? Nothing's been indicated to me. Thank you for that. Thank you. And that leads us to item 11 then, to confirm the date of the next meeting, which is Thursday, the 3rd of August 23. Thursday, the 3rd of August 23. Can I thank everybody for their interest in this meeting today and for the questions and comments made in the discussion as well. And thank you for reaching the conclusion of this business. I remind board members that there's a closed board meeting to follow, but I suggest we take a 10-minute break and we convene the closed board meeting at 12 o'clock. Okay. Thank you very much. Thank you very much, everyone. Thank you.
Thanks, everyone.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Cheers.
Thank you.
Thank you.